Good afternoon, everyone, and welcome to the 81st episode of the COVID-19 webinar series at the Royal Society of Medicine. 81st episode kind of says it all. And this is for health professionals by health professionals. My name is Margarita Burmester, and I'm a consultant in paediatric intensive care and president of the Paediatrics section of the Royal Society of Medicine. Today's episode, we'll be discussing the question, should we vaccinate children? And I'm delighted to introduce our two panel members who are leading experts, Professor Beate Kampmann and Professor Russell Weiner, who will bring their insight and latest knowledge and findings to this conversation. I would like to introduce Professor Beate Kampmann, who's Director of the Vaccine Centre at the London School of Hygiene and Tropical Medicine. Welcome, Beate. And we also have Professor Russell Weiner, Professor of Adolescent Health at the UCL Institute of Child Health in London, and who also attends SAGE. Welcome, Russell. As we know, despite the success of its vaccination programme and the lead of other countries, including the US, the UK has not yet made a decision on whether to vaccinate children aged 12 to 17. We've had over 100 questions sent in from our audience, of which I'll be presenting themes, including the potential risks posed to children by COVID-19 and the vaccine, their role in community transmission, and the ethical questions surrounding vaccine equity and the global need to our panelists. You can also write live questions in through the Q&A box within Zoom, so please do so, and also upvote questions that you see, so then I can see them rise to the top of the box and address them if we have time. We'll try to cover as many questions as people have. So with that, I would like to start with a brief overview of some of the issues through one question to each of our panelists. And I'd like to address the first question to Russell. So Russell, could you describe to us in 3 minutes, why should children miss out on the benefits of vaccination?
Thank you. This is all about the balance of risks, the balancing the risks and the benefits. So SARS-CoV-2, the risk of death in this country is about 1.5 million for children and young people. The great majority of those, of course, are clinically vulnerable. The risk of coming to intensive care, so having severe disease, is about 1 in 50,000. These events are exceptionally rare. We don't know exactly how many of our children and young people, of which there are about This is about the balance of risks. The benefits to them of being vaccinated are very, apologies, I don't know if you can still hear me. The benefits to them of being vaccinated are very low. The risks are unclear. We have data, published data from trials on around 3,000 teenagers from the Pfizer trial. We have a press release on the Moderna trial, suggesting again that vaccine is very safe, but those data are not yet published that I know of. So we actually have very little safety data. The safety bar is much higher. So I agree that in a logical world, there are many reasons, and we'll discuss them, why children should get the benefits of this vaccine, but the benefits to them in a direct sense in terms of health are little. There are some issues around educational benefits, and I'm sure we'll come back to those. Thank you.
Thank you very much. And now I'd like to ask Professor Kampmann, could you answer this question in 3 minutes? Is it ethical to vaccinate children to essentially protect adults?
Yeah, thanks, Margarita, and thanks to the Royal Society for inviting me. My name is Beate, just for future pronunciation. I know I have an odd name. The title, Should We Vaccinate Children, is actually absolutely yes. And should we vaccinate children against COVID? That's what we have to debate here. Now, there are precedents for vaccinating people, not just for their own health benefit, but also for the benefit of society, if you want. And in a sense, vaccination in itself is always an intervention that protects the individual, but ultimately also our communities. And this is where the equipoise to some degree needs to be struck. So if we just for a moment think about the rubella situation, we use the rubella vaccine in boys and girls not to necessarily protect them against what is essentially a fairly harmless infection, but primarily to protect pregnant women from a condition that is the rubella embryopathy. So, you know, we're already used to using vaccines for essentially the greater good for others. So I don't think COVID is particular an exception there. And in a sense, you know, to think that we'll only be vaccinating children against COVID to protect the community is probably not correct, because we also, I mean, Russell has given the numbers, whilst the risk is very low, we've also seen, you know, the evolution of long COVID in children. And again, it's a rare condition, but it can also be very debilitating. HPV is another example where, you know, although the vaccine is of benefit to boys for rare cancers, it is essentially also of benefit to the girls if the boys are vaccinated, because the transmission of the HPV virus is interrupted.
Thank you very much. And that covers actually quite a few of the questions that have been sent through previously, and also some of the Q&A questions posted now. Can I ask, a specific question that was sent in by Angela Burnett to Russell, please. She asked, should vaccines be sent to countries with less access to them rather than vaccinating our children in order to reduce variants?
I think that's a very useful question. And I don't know that we know, well, there's no easy answer to that. That's part of the set of ethical dilemmas around vaccinating children. If we decide to vaccinate, I mean, let's be clear, we need to separate vaccinating teenagers from vaccinating children. Data for teenagers are available from trials, and there will be also data from use in the US and a number of European countries that are emerging relatively quickly. We have almost no data on children under 12. There are no published trials. Trials are starting or are ongoing. But let's be clear, this is about teenagers at the moment. There are strong arguments that the benefit will be so marginal for vaccinating our teenagers that what we should be doing is not vaccinating our teenagers, but contributing towards international vaccine supply. I have a lot of sympathy with that argument. I don't think it entirely trumps the need to vaccinate some of our teenagers, those particularly that are clinically vulnerable. These are a relatively small group. I think over time, once vaccine supply is less of an issue, we should, my personal belief is we should be vaccinating our teenagers at the same time as contributing towards international supply once we have adequate safety data. Thank you.
Thank you very much. That kind of follows on to a question to I'm going to say it wrongly, Beate.
Just think of Beatrice.
Thank you. From Sabine Lenton, who wrote in and said, would it be worth considering adolescents 16 to 18 separately, considering post-puberty status and data from the Pfizer vaccine?
Yeah, so the Pfizer vaccine has tested 2,290 adolescents in between the age of 12 and 16. Only half of them would have been given the real vaccine, the other half would have been given placebo. So the data that there are actually divided into age groups. And I don't think that one can call an age group as post-pubertal when you've reached 16, as opposed to when you're 12, 13, 14, etc. I think this is really quite a wide spectrum. I don't think there'll be the granularity in the immune response between 12 and 18 that lets you go to what would be really a very personalized immunization system, especially in the context of a pandemic. The bottom line is that the immune response in terms of antibody production was excellent in this age group. In fact, it exceeded the antibody that is produced by adults and the elderly people. And there's only really the group of people who've had COVID before who have higher antibody in response to vaccination compared to this group of adolescents, which I would refer to between 12 and 18 or 16. So I don't think there is a need to differentiate the group between 16 and 18. The question that arises is whether the dose that can be given to young people, given the fact that they make very good antibody response, needs to be as high. And in the over 20 trials that are currently going on involving children, and which can be seen in a summary on our vaccine tracker at the London School, there are actually dose-finding studies and also interval studies. So a lot of science is still very much in progress. As Russell also said, we won't have that data for a while. The majority of these trials are phase 1, phase 2 trials, and efficacy trial data will really take a while to come through. And I don't think there is at the moment a need to stratify for teenagers according to sub-age groups, but we might want to think about whether doses or intervals could be differently handled in the future, but we don't have the data to back that up yet.
Okay, that sounds very challenging. It'd be great when the data come through. I have two questions for Russell. It's one essential question. They're the same theme about consent, sent in by Jane Lamprell and Prof. Morgissi. And they're what if the parents of a child do not consent should children's vaccines come through? Should there be a survey beforehand conducted by school? And by Jane Lamprell is, will Fraser-Gillick competence apply to kids less than 16 years old if the child wants to be vaccinated, but the parent refuses consent?
Oh, good issues, good issues. I think the first thing to say is that I think we're right to be concerned about vaccine hesitancy in vaccinating children and teenagers. Let's think about teenagers for the moment. There's some data released this morning from the Schools Infection Survey where they actually asked parents about intentions to vaccinate, and only about 40% of parents suggested that they would intend to have their child or young person vaccinated. But this is the issue with surveys, of course. I think it was only about 5% said they would definitely not. So the great majority of parents a large majority appear to be undecided. Given that the benefit risk balance will be quite finely balanced for teenagers, it would be no surprise to see more hesitancy because of that. The Fraser guidelines are clear that young people, particularly teenagers who are deemed competent, if they they're fully informed and competent, can consent to taking treatment against the wishes of their parents. So there's a requirement to assess and prove competence. Then there's a requirement for them to be fully informed. And then there's a requirement for them to have, for the caregiver to have discussed and tried to get the young person to work with the parents. I don't know specifically about vaccination. Beate may know more about that, but I think those general Fraser guideline principles would absolutely apply here. And I think they should apply because young people, if competent, should be able to make their own decisions. In terms of the second question, what should we be doing? I think there's a number of steps before we actually roll out children or teenagers vaccination. Schools are almost certainly the best platform to provide COVID vaccines to healthy teenagers if and when a decision is made to do that. Undoubtedly, I suspect quite a lot of communication with parents will be important, both at a national level, but also by schools and others who are providing the vaccines. It's interesting, I'm sure you know the data, but I was surprised to learn that we only ever got to about 50% in our child influenza vaccine levels in places such as London, and I think it was around 60% nationwide. And there are a whole series of unanswered questions about how high we need to get our teenage vaccination rates if we do decide to vaccinate teenagers to contribute to overall benefit to the population. I'm hesitant to use the word herd immunity, but in terms of overall benefit to the population, I think it is unclear. But what is clear is that we can get that for influenza with relatively low vaccination rates amongst children. Thank you.
Thank you very much. And Beate, would you like to comment on, Russell was talking about the vaccine rules, as it were?
Yeah, so I mean, as a principle, we haven't made vaccination mandatory in any context in the UK. And I think that is an enormously important principle. And I would totally support that the decision should be made jointly with teenagers and their parents. And I agree with Russell that the Giller competency principles apply in the same way. I'm not aware that there is any particular formulation around vaccines in that case, but there might be good precedents through the HPV program, because it might have well come up in that context, because these will be young people under the age of 16 usually be offered the vaccine. So, but I think, you have to listen to parents' concerns, and I think it's very important to keep in mind the times when these surveys were done. So we did one on vaccination in pregnancy and whether pregnant women would be willing to be vaccinated themselves and also have their babies vaccinated. And there was about a 60% rate of people who would say yes, but there was also a middle ground. They didn't say no, but they wanted to know more. But that survey was done in January. And, if you ask the general population, now that we've so widely rolled out the vaccine program and things are going fairly well, we have more and more people who are engaging in vaccination. And I think it's that middle ground of people who just want to have that little bit more confidence and that little bit more reassurance from actually seeing the real situation. And I think as that rolls out also in the countries that are now vaccinating 12 to 18-year-olds, and there are plenty of them, Israel, several countries in the EU, Canada, the US, we will get more confidence, because a safety database of 1,500 kids from a clinical trial would not necessarily convince a parent with very legitimate questions.
Thank you very much. And following on from that, do you know both Anthony Scaffardi and Clarion Johnson sent in questions about whether there are any plans to roll this vaccine to under 12s? And are there any trials underway that we ought to be aware of featuring children under 12?
Yeah, so I think the program is not prioritizing or thinking about enrolling. None of the vaccines that we've got available in the UK are approved for children under 12. So that's for starter. The priority of the program will be to complete the second dose in the adults before anyone will go near the children, is my guess on this. The younger children's data are not out there yet. So if you want some real transparency on what's going on in the various trials, there's about 27 of them. So there are various phases of trials. If you go to the vaccine tracker at the London School Vaccine Centre, they're all listed there. You can search for the trials that are enrolling children. The majority of them will not have under the age of 12, up to the age of 6 months, actually. There are quite a few trials. I think there are at least 5 or 6 that are enrolling children between the age of 6 months and up to 15, 16 years of age. So you can look that up, but you will also see that these trials are only just started, and we are not expecting to have lots of data from them in the next 12 months.
Okay, that sounds like a fantastic resource to go and check and see what's
I'll
happening.
stick the link in the chat box if that's any use.
Yeah, that definitely. Thank you. Right, over to Russell. So there are a host of questions, not only on the Q&A, but also submitted prior to today, to do with long COVID and PIMS TS. They've been submitted by John Lilly. What implications does PIMS TS have when considering the unknown side effect profile of vaccines in this age group? Elizabeth Thomas, is there evidence that those children who become symptomatic with COVID end up suffering from long-term COVID? So the same children. And Harriet Home, should, slightly different, but should vulnerable children with chronic diseases be a separate category and be vaccinated if others aren't? So really the medical issues of COVID and implications.
Thank you. In terms of PIMS TS, it was very interesting, and I was peripherally involved when this new pediatric multi-system inflammatory disorder was first noticed and then described. And again, I think it's one of the things we can be proud of, that it was first recognized in this country. And that's because the join up of our health system, the way people work together, the sharing of data, the fact that we have a national health system in this country was an important element in allowing us to recognize this. I'm going to refer some of this back to Beate, who will be better qualified than me to talk about some of the immunology. But I think that PIMS TS reminds us that children and teenagers have immune systems that are different to adults. There is some overlap of PIMS-TS with adult disease, but it is particularly a condition that affects children. Beate has already mentioned that the adolescent trials show very impressive responses, antibody responses to vaccination. And we also know that children and young people have, young children have quite different immune responses to even older adolescents and adults. That I think counsels caution. And it's one of the reasons that the safety bar for vaccination needs to be very high for teenagers, but I think exceptionally high for children, particularly when the risk balance is either very finely balanced or only balanced towards vaccination when you put the benefit to others in there. I think that means that the safety bar needs to be very high. I'll come back to Beate in terms of more about PIMS. The issue about vaccinating vulnerable children, absolutely. Death and severe disease from COVID are exceptionally rare, as I said. It's about 1 in 500,000 rate at risk of death and about 1 in 50,000 risk of severe enough disease to come to pediatric intensive care. That is not nothing, but clearly it's rare. The vast majority of those, I think, and I have the data, they're not yet published, but will soon be out, around 260 children and young people admitted to pediatric intensive care units in this country with COVID. I think only 22 of them didn't have significant underlying comorbidities. And they, of course, were the comorbidities that you would imagine, particularly significant neurodisability, cardiovascular, respiratory, etc. So only a very small proportion are in children without known comorbidities. It's also quite likely that those who come to pediatric intensive care with severe disease with no known comorbidities may well have an underlying genetic abnormality or risk for severe infection, because I understand that's found in other infections in apparently healthy children. So if I was a betting man, I think that the JCVI will approve vaccination for teenagers who are clinically vulnerable. Because I think in that group, you can argue that the benefit to them is sufficiently high. Again, I worry about the lack of safety data. And it may be that they decide that it's potentially a priority group that should be vaccinated when additional safety data are available from the rollout in other countries. The issue about long COVID, there are very few data available. And I think we need to be very careful about what I think are better called post-COVID syndromes or post-COVID conditions in children and young people for a number of reasons. Firstly, they're very real. And I think PIMS has told us that. In one sense, PIMS itself is a post-COVID syndrome. And the number of children we have with significant cardiovascular morbidity from that is very low, but also very real. We need to be careful, however, about the claims we see that, for example, 1 in 10 children or other claims such as these, which come from uncontrolled studies. We need to remember that many of the symptoms, such as very significant fatigue, are very common in teenagers. Some work I did quite some years ago, about 40 to 45% of teenagers will tell you that they are extremely tired 4 or more days a week. And that was well before COVID. And that is the burden of growth and going to school and being a teenager. So we need to be quite careful about that. Similar with some memory issues and others, they're actually relatively common in the population. We had the same problem when we were looking at COVID itself, because actually the overlap between symptoms of infection and normality in children, or whether it was normality or other respiratory viruses, was exceptionally high. There's a number of quite large population studies that found the same prevalence of things such as sore throat or runny nose or a bit of a fever, regardless of whether you're infected or not with COVID. I think the answer is we just don't know. I think we need to be very careful. We need to not just jump to assumptions either way. We need to be open and recognize that a small minority of children have very significant morbidity that comes out of this condition. But I think we absolutely need to await controlled studies to look at when people start making assumptions about long COVID more generally. The issue about whether it's more common in symptomatic children, I think, is unknown. But the NIHR has funded a large study undertaken by a number of colleagues at UCL and Imperial and elsewhere to look at this, I think aiming to recruit nearly 30,000 children in a case control study. And that's the kind of thing we need to resolve some of these questions. Thank you.
Fantastic, thank you. That was very encompassing and desperate. We all want the results now. You made a reference to Beate to help with the answer on PIMS, to contribute, sorry, not help.
Yeah, so you know, as Russell's already said, it's a rare but serious condition. I think one of the differences to the long COVID situation that we see in the adults, the way I understand it, it's often a continuum of the way that the acute disease has been impacted on the body. So in adults, you usually have people who've been in intensive care who've been really sick, who then continue to have ongoing symptoms. That's not the way it manifests itself in children. In children, the majority of the ones who've been admitted with PIMS, and as Russell knows, Liz Whittaker and the people from all various hospitals in London have really contributed to describing this syndrome, usually come in with a little bit out of the blue. They don't have a diagnosis of active COVID few weeks earlier, and we find that they have antibodies. So they clearly had COVID infection, which in the majority of them has gone unnoticed, although they're often family contacts. So it is an immune dysregulation disorder, as probably is long COVID as well, but we really need these longer term follow-up studies to understand more about the immune mediators that are involved. And also what is quite reassuring, I mean, we have thrown a lot of immunomodulatory drugs at these children for better or worse. The study of using IVIG versus steroids versus the combination of both has just been published in the England Journal. And it shows actually whatever you do, the majority of them get better. And that is really reassuring information for parents. One comment I want to make, which will interest Russell as well, and I'm sure he's got similar comments. I mean, on the general pediatric side, Russell, we've really seen an unusual amount of young people with mental health issues. And I find, as much as, you know, obviously there are many teenagers with many issues all along, fatigue, etc. But I do think, without having the exact denominator, it's hard to know. But just from the impression of being a clinician in the service, I really feel that has hugely increased. And that might be very much environmentally triggered, might not be an immune response, but there might be some organic components to that too.
Thank you very much. I have one more question that is mirrored in some of the Q&A, and then I'm going to go to the top of the list of the Q&A and address them in the last 15 minutes. So and this is for Beate. Rupesh Krishna Kunti and Mashal Al-Nawab sent in questions about, on similar lines, but what could be the long-term effects of mRNA vaccine in children? And can we consider vaccinating children when we are not sure if mRNA vaccines do not cause autoimmunity in the long term? And in addition, Christina on the chat has written, what are the current thoughts towards the data appearing from Singapore and Japan regarding the mRNA spike protein potential attacking the ovaries and liver?
All right, so I think this all alludes to the fact that clinical trials only have a certain number of people enrolled. They'll never be able to tell you all of the shorter and longer term side effects. And you've seen that also with the occurrence of the thrombocytopenia thrombotic syndrome that we've seen in the context of the vectored vaccines. And you might be aware that there was a signal around young fit men or young men getting myocarditis in the context of the second dose of the mRNA vaccine. So there is, you can never say that there is no risk. However, biologically, first of all, as Russell said, it's always a risk-benefit ratio, and the calculations show very clearly that these are extremely rare events and that the benefits for overall control of the infectious disease in the community far outweighs the risks. And that's also true for these unfortunate but existing side effects. I don't want to comment on the spike protein, ovaries, liver, what have you. These are not substantiated claims. They play right into the hands of the more militant anti-vaxxers that are out there as well. The biological plausibility isn't there because the RNA or the mRNA in the vaccine is extremely quickly destroyed at the level of literally the injection site. And of course, you know, with a product that's been around for just about, not even a year, there's no way of predicting long-term effects. But it is also, you know, that's why we have a surveillance system. And that's why we are collecting data on outcomes with the yellow card system. And that system is really very robust and very, very well established. So I think it's important to keep an eye on all of this. And it's not going to be easy if we're starting mixing and matching the various vaccines, because I think that's hard then to disentangle if there are any longer term effects. We are in a situation of a pandemic, and I think we need to really carefully understand what the benefits are for the most vulnerable people and then worry about side effects that we don't even know exist. And so far, we have no evidence that the vaccine causes autoimmunity. We have no evidence that the vaccines cause advanced disease enhancement through antibody. These were things that were, contemplated that could be a reason. But you know, we have to watch it. It's a question of how much risk are we prepared to take to deliver a level of protection that everybody needs.
Absolutely. Thank you so much. That's very comprehensive. And I'm learning a lot here. I'm now going to move to some of the questions. Well, first of all, the announcement that to the social pediatric issue to address to Russell, and also read out some of the questions that we have in the Q&A. So they've said that the bubble business can stop for schools on July 19th, which is actually when most schools stop. Thank you very much. As a parent with 3 children, I really appreciate that. Sharon Kefford has put in the chat, would vaccinating children stop the need for self-isolation when everyone has to have problems with school? And there's another story which I can empathize a lot with, because it is a big struggle as a working parent, from Aswin Kumar Vaziret. I can't see the rest of the name. So I'm a consultant myself, and my son has been advised to shield even now till he is vaccinated. This recommendation comes from his pediatric team. He has not been to school since March 2020. He's also 6 years old. So what am I meant to do? Keep him home and off school forever? My wife, a GP, has left her job to look after him. Why can the vulnerable group not be vaccinated, and how long will we have to wait? Forever? So awful stories. And Russell, comments?
Thank you. I think the first question was about bubbles, wasn't it? When all the adults are vaccinated, one of the real concerns I have is that children and young people will then be the only substantial part of the population that are not vaccinated. I recognize we won't get to 100% adult vaccination, of course, but actually as a large population group, it'll be children and young people. And then we will make true what has been claimed all through the pandemic, that children will be the source of most infection. That hasn't been true during the pandemic. It's been a claim, and it's been a very difficult one for us involved in child health. Let's not go into all of the details of that. But what we will do by vaccinating all the adults is change the dynamics of this pandemic, thus that children and young people become the source of most infections to vulnerable adults. I think that's one of the reasons in my mind that we should think about vaccinating them. The bubble isolation policy that which is a test to trace and isolate system that we have used in our schools, is quite different to the test, trace and isolate system that is used for adults. And it's slightly unclear why that is. Schools are very easy for us as adults to manipulate. It's very easy to worry about transmission in school and send home entire bubbles. It's quite a rational policy, and I think it's been very effective, but I think there are real equity issues about it once all the adults are vaccinated. The specific question you asked me, I think, was, will we be able to dispense with isolation if we vaccinate children? And I think that's actually, I think my answer would be what we need to do the same for children as we do for adults. We need to think about equity. Again, I think having a different test, trace and isolate system in schools compared to what we operate for households more generally is actually brought some inequity. And I think that needs to be rethought in an evidence-based way. It's unclear whether a vaccinated person, I mean, we know that vaccines aren't perfect. We know that they're probably, let's not average out their effectiveness, but we know that small but real numbers of those who are so-called double jabbed do get infected a second time. So it may be that isolation will be required in some sense for significant contacts for those who are vaccinated in the future. But I would argue the most important thing there is equity across children and adults. Was there a second question I haven't answered, Margarita?
No, I think that covered everything. It was the desperation of
oh, sorry, the clinically vulnerable.
Yeah.
Yes. So clinical teams need to provide you with advice. Talking to the person who asked the question, and clearly we don't know the circumstances there. The advice from the college, Royal College of Paediatrics and Child Health on shielding, of which I was president up till about a month and a half ago, but they now have a much better president, Camilla Kingdom, is that there are almost no children who are so clinically extremely vulnerable that they cannot go to school. I think the data on shielding and which children actually need to shield is ripe for revision and will be being revised by the CMOs, and the college will be involved in that over the next while. But I absolutely recognize some of those issues, and I think as a general sense, almost no children need to shield. There may well be some incredibly vulnerable, incredibly small number of individuals, and I don't know whether the case in question falls into that. One of the things that's sad is that there have probably been far too many children shielding through this pandemic that actually, given what we know now, almost certainly didn't need to shield to the extent that they did, which is in some senses a product of our ignorance over time. Over.
Thank you. Yes, well, I guess we have ignorance because we're learning as time passes, as the data comes through. So we have time probably for one more question. And I think what I'll do is I'll choose the top question, which is on this Q&A, which is from Harriet Home. We discussed some of these issues, but not the specific ones. So it says, would it be possible to also discuss benefit of vaccination for children with regards morbidity, not just mortality, particularly for children with underlying vulnerabilities such as cystic fibrosis? My understanding is that we don't know the true risk to this group of children since the cystic fibrosis population have primarily shielded to avoid SARS-CoV-2. Thank you. So it kind of follows on. If I could address that to Beate.
Yeah, thanks. Just one comment on the previous discussion, because I think it's important to understand that actually the bubble system in the schools has not been systematically evaluated, Russell, as far as I have understood. And I think this is a missed opportunity. And to everything that you've said, I think if these policies are put in place, I think we have a duty to actually also assess the impact, and schools are a fantastic environment to do that in. And I really hope that this isn't going to happen again, because we could have learned so much from, you know, how many, we know that the majority, for every single child that is symptomatic gets sent home, 20 other kids got sent home, hardly any of them got COVID. So I don't think the bubble system in the way that it's handled at the moment is sustainable. Okay, going back to the vulnerable children, I mean, we have from the data of children who've been hospitalized with COVID, we will have breakdown of comorbidities because thanks to the relatively established and good data capture system in the UK, also through primary care, this would be possible to trace. And, you know, as people are looking into that, I am not sure how many people, how many children with cystic fibrosis got COVID as opposed to, you know, and obviously they're not being exposed to the normal situation. But, you know, the risk, given the fact that the risk of circulating virus, to meet a circulating virus now is much lower now than it was, let's say, in the autumn or in the spring, their risk is proportionally lower as well. And as we have, you know, now 87% of the population having got at least one dose, 67 have got two, the amount of circulating virus is going to be much lower. Therefore, their personal risk is going to be lower. It's not quantifiable because there could always be bad luck. You can only argue this in statistics. I think the fact that people around vulnerable children are now vaccinated is a huge advantage because that will also reduce the risk of transmission to the kids. And, you know, I think like in Germany, for example, the policy around teenagers has been restricted to vaccinating just the vulnerable groups. And the vulnerable groups have been identified. And I would have thought that children with underlying lung conditions are part of the vulnerable group. And one would want to push for introduction of vaccines in those children in particular, because their risk-benefit ratio will be slightly different from, you know, any other child in the community.
Absolutely.
Thank you very much. Yes, go ahead.
I very much agree with Beate. Absolutely. And as I said, I think it's odd that we have run a different test and trace and isolate system in schools compared to the rest of the population. When actually the secondary attack rate data from schools suggests that the risks of transmission is lower than in households. It's almost been the reverse. And absolutely, in terms of data, and I can share with you that there should be a preprint coming out addressing this exact issue in terms of which children are extremely vulnerable using linked national data sets from across England, should be coming out next week.
That's great.
Thank you very much. Well, from a personal point of view, I've got 3 children and they need to be vaccinated as soon as possible because we're all going nuts in this household. So there has to be some social, mental health aspect for families. Anyway, that was fantastic. We've probably come to the end of the session. I don't think we have time for another question. So that was a wonderful wonderful answers. Thank you very much. It's been very knowledgeable for me, and it's great to know that there's all this work happening, and it just illustrates how difficult it is to give answers to questions when it is a learning process, and almost on a daily basis we're learning more with the data that's being collected. So let's hope that the summer will produce more data, and the school year next autumn will be different from the ones that we've had for the last 2 years. So thank you so much to our panel members and audience for joining the session today. Can I remind everyone that the Royal Society of Medicine is now open for visitors. So the library, the club, the hotel and meeting rooms are all open for business. Next week, there's a special extended episode of the COVID-19 series called Spotlight on Long COVID for all those people who posted questions on long COVID. This will be a 3-hour paid-for program, bringing together the most up-to-date clinical knowledge. Not that you've heard it all today, but it'll be more up-to-date after a week about long COVID from leading researchers, expert clinicians, and patient voices. So thank you again, everyone, and have a wonderful afternoon. Hope you enjoy the sunshine. Okay, bye.
Bye.
Thank you, bye.